webinar number 182 since the Andean Health Organization, Hipólito Unánime Agreement, started the webinar series in May 2020. On this occasion, we are pleased to inaugurate a new series, International Innovations in Health, with the first topic, how are we doing against leukemias? The Andean Health Organization is committed to working for the health of the Andean region, together with the Ministries of Health of Bolivia, Chile, Colombia, Ecuador, Peru, and Venezuela. The COVID-19 pandemic also teaches us that the capacities built and strengthened in these 3 years must not be rolled back, and that health must remain at the center of policies. Research, epidemiological and genomic surveillance, vaccine and drug development, and the deployment of health promotion and prevention measures are essential for a caring society. Reflections on these and other priorities relevant to health and well-being can be found in the monthly Noti Salud Andinas newsletter available on the Andean Health Organization website. We invite you to leave your name, organization, and country in the comment box of the Facebook Live or YouTube Live chat. In the same space, you can leave your questions or send them via email to webinars@gmail.com. In this webinar, we will follow the usual dynamics. We will start with the institutional greeting, followed by the presentations of our speakers, and then we will move on to the Q&A session. To access the certificate of attendance as usual in any of the chats of Facebook Live or YouTube Live, you will find a fixed link where you must fill out a brief survey and leave your data as email. Please make sure that your email is correctly written for sending the certificate. To begin this important day, I give the floor to Dr. Maria del Carmen Valle, Executive Secretary of the Andean Health Organization, who will give the welcome and institutional greeting. Go ahead, Dr. Valle. Thank you very much, Forley and Ruby. The field of medicine is always innovating, and the Andean region cannot be a stranger to this progress, especially when one of the objectives is health sovereignty. For this reason, today, we begin the special webinar series on international innovations for health with leukemias, a topic in which the hidden pandemic of cancer and the life courses of infancy, childhood, and adolescence converge. The WHO Global Cancer Observatory, GloboCan, shows that leukemia is the most common and most lethal cancer in the first 24 years of life. According to data recorded globally, 3 out of every 100,000 children and adolescents developed leukemia in 2020, and 1/3 of the total number of children and adolescents with some type of leukemia unfortunately died. In the Latin American and Caribbean region, the figures are more concerning. The incidence of leukemia in 2020 was 4 out of every 100,000 children, and half of the total number of children with leukemia or some type of leukemia unfortunately died. In addition to the general data, our countries suffer from inequities in the various processes necessary for the prevention of leukemia death in children and adolescents. Problems are addressed by various local, national, and international initiatives, whose recognition is key to continue joining efforts. Therefore, today, we welcome Dr. Sima Eja, expert in leukemia children of the St. Jude faculty and director of the St. Jude Global for the Eastern Mediterranean region. Dr. Manuel Rodriguez Orellana, coordinator of the Leukodynamics project and director of the Cell and Gene Therapy Unit of the Niño Jesús Hospital in Spain, and Dr. Arturo Zapata Lopez, pediatric oncologist of the National Institute of Neoplastic Diseases, Peru. We thank our speakers for their valuable participation, and we also thank the public who will contribute to the important dialogue on the innovations, opportunities, and challenges facing leukemia. Welcome all. Thank you very much, Dr. Calle. After the greeting of our Executive Secretary, I introduce myself. My name is Forli Chavez Romero, public health and global health professional who participates in the action line for the Cancer Control Indiana Health Organization. Today, I will be in charge of moderating this meeting. After this preamble, we warmly welcome Dr. Sima Jihad. Dr. Sima is a pediatric hematologist oncologist in the Division of Leukemia, Department of Oncology at St. Jude Children's Research Hospital. She's also part of the pediatric group leukemia department. During her stay in the MD Anderson Cancer Center, she had several administration positions. In 2003, Dr. Sima was hired by the Leukemia Lymphoma Division in St. Jude's Hospital in Memphis, where she has worked as a principal investigator of the first-line study on lymphoblastic acute leukemia and several studies on leukemia. In 2017, Dr. Sima works in the Department of Global Pediatric Medicine of St. Jude. Now is the head of the program of Eastern Mediterranean. Dr. Sima is working on leukemia to help all the global partners in St. Jude for diagnosis, treatment, and support for children with lymphoblastic acute leukemia worldwide. It has, go ahead, here, Dr. Sima, welcome. You need to activate your microphone.
Sorry about that. Thank you all. It's a pleasure to be here. And over the next 20 minutes, I will try to give you a high-level view of the challenges of applying the innovation to leukemia, to improve leukemia outcome globally. So, as you probably all know, in blue, you can see that in low and middle income country, only 1 of 5 children will be cured from cancer, whereas in high-income countries, shown in red, 4 out of 5 will be cured. So there is a very large discrepancy in outcome. This is more significant when you look at the number of children that live in those countries. So you see that most of the children in the world, shown in blue and the blue dots, live actually in the low and middle income countries. So when you hear that where you live really dictate what your outcome is, it's very important to understand that it's a moral obligation to make sure that all children, no matter where they live, especially in the low middle income country, have access to quality care so they can have good outcome. This slide shows you the results on the St. Jude ALL study, and you can see that over the years, we have done progress. In the 60s, less than 20% of the children with ALL will survive, and now it's the reverse. Now over 90% of children with ALL will survive. We have achieved those results in successive studies that have improved the outcome gradually. But it is sad to see that whereas the outcome is over 90% in the high-income country, in the low-middle-income country, it's still where it was in the 60s in the high-middle-income country, below 20%. This is even more challenging these days because with technology, there is significant improvement in the way we diagnose leukemia, and there are many new therapies that are available. So when you look at the slide, the upper paragraph, the therapy elements, the classic therapy elements, it's what we have been using to improve outcome of leukemia. But now there are new development, immunotherapy and molecular therapy, that are rapidly replacing or helping the old element of therapy. And I will go over those to show you why the challenges in innovating to improve the outcome of leukemia globally is becoming greater. So this is a slide summarizing the main immunotherapy approaches that are now available. And I would like you to focus on the fact that no matter what we are using, whether it's bispecific CAR T cell or conjugated toxins, you see that the survival of patients treated with those new agents is much superior to those of the patient treated with the classical chemotherapy. So those agents are very effective and they are quickly replacing the classic chemotherapy, especially in relapse patients. What are the challenges? The challenges are they are not easy to administer. So obviously, the more low income the country is, the more difficult this will be to implement. Also, the costs are prohibitive, even in high middle income country. So you can imagine how difficult it will be in low and middle income countries. Two main studies have shown that blinatumomab, the bispecific anti-CD19 antibody, in two studies have shown great efficacy. In the US, it was given to work in the backbone of relapse leukemia. 2 courses of blinatumomab replaced 2 courses of chemotherapy. In Europe, the same concept with 1 course of blina replacing 1 course of chemo. What are the results? In the US study, you can see the patient who received the 2 courses of blina did much better, both in event-free and overall survival. Not only the responses were better with the blina than with the chemo, but the side effects and the complications were less. In Europe, Dr. Lucatelli showed the same. Patients who received blinatumomab do much better than patients who received the chemotherapy block. More studies have come since focusing on infants. As you know, infants have a very difficult to treat leukemia, and the outcome are even worse than in older children. And you can see when given blinatumomab, those infants had good event-free survival compared to historical control. And recently, a paper published in the New England Journal showed the superiority of regimens containing 1 cycle of blinatumomab. At the same time, the adults are now combining the blinatumomab with molecular therapy in Philadelphia positive ALL, another very high risk leukemia, and they are showing very good results. So the message is immunotherapy and molecular therapy are expensive, are not available to every country, but they are the future and they will be moving into frontline therapy soon. I have one slide on CAR T cell because similar to the Blina, CAR T is also very effective. It's a one-time treatment, but it's even more complicated because you need a system for collection, for manufacturing, and for infusing. So this is even more difficult to give than the Blina. So I told you very briefly about all the new agents that are very exciting and available to high-income countries, and about the challenges in cost and administration that makes their access in the low-middle-income country difficult. But we should not forget that the road to cure has many more elements beyond just one treatment, and that to build the center that can actually give those new innovative therapy, it takes more than just having this agent to give. So you can see on this road to cure that it's very important that in a country there is awareness of both the public and the providers to recognize the symptoms of leukemia and refer the patient, because currently it's suspected that about a quarter of children in low-middle-income country don't get even diagnosed because their symptoms are not recognized or they don't have access. Once they are diagnosed, the problem is with hospital arrival, with referral. So you need a healthcare system that refers them and a hospital that have the capacity to accept them. You need transportation and all the social support for the family to get to the hospital. Then, of course, there is the accurate diagnosis and the good treatment. And I will go fast over those here because I will focus on them in the remainder of the talk. But then when you finish the treatment, there is the survival. So all those elements are all present in high-income country to make sure that no step is missed, because any step that's missed will affect the outcome. And this is why, with the reminder of the talk, every collaboration I talk about should involve the hospital, an international collaborator assisting, or international organization assisting, but most importantly, champions on the ground, both doctor, healthcare provider, and foundation, to do all this work and to make it sustainable and scalable. So focusing on the diagnostic and the treatment, those two are very important, and there's a lot of innovation going in both of them, as I mentioned earlier, because of the technology, advances in technologies that's taking place. And it's very important to have the right diagnosis when the patient comes, because leukemia is several subtypes, and if you don't diagnose it correctly and start the treatment, which is a wrong treatment, then you have lost your chances for cure. Then when the treatment starts, in addition to the challenges to have the treatment adjusted to the risk group, you need to make sure you have the drugs to treat the patient, and we know about all the drug shortages that are available. You need to make sure that the treatment is not too toxic to where the patient can die from the treatment. You also need to make sure that during the treatment, the patient doesn't abandon therapy. And many times the abandonment is because either of lack of social support and money, or because the treatment is toxic and the patient stop coming because they feel they are very sick and they cannot tolerate the treatment. So continuing to talk about diagnosis, I want to show you that there have been progress from making the risk group and the diagnosis based on clinical, the age and the white count, up to now the molecular, passing through the phenotype and microgenetics. Why this is important? Because when you diagnose based on the white count and the age, clinical, you get a small picture of what the risk group is. But then with the phenotype, you can differentiate between B and T cell, which is very important. Then with the macrogenetics, this is how we discovered the Philadelphia ALL. And then we needed the molecular to discover the Philadelphia-like. So really, you need to make those diagnoses. And as you can guess, moving from clinical to molecular requires money and expertise. And there is disparity because in most low middle income countries, they have clinical and phenotype and very rarely have the genetics and molecular. This is important because this is a graph from a St. Jude study. And you can see that although I showed you the survival overall is more than 90%, it depends on your genetic subgroup. So some subgroup do not do well. And if you don't have the accurate tool to diagnose them, you will miss them and you will not be able to save them. And you will see that their outcome will drop significantly. It is even more important because this shows you that many of those groups can be targeted by molecular or immunotherapy. And those high-risk groups now, when we identify them, we are starting to treat them with the immunotherapy and molecular therapy that I discussed at the beginning of the talk. And in countries that don't have access to those, they will end up being not able to treat the high-risk leukemia properly. And unfortunately, there are several publications indicating that high-risk leukemias are more common actually in low-middle income countries, like the Philadelphia-like, which is a high risk, is more common in Latin America than it is in the US, for instance. So how do we get to give equity and to have everybody reach the fruits? It's not equality. It's not giving everybody the same tool. It's giving everybody the tools they need to get to the same point. So at St. Jude, when we train the people and they go back home, we stay in touch with them. And we have had this program to where it's called International Outreach, where we have done what's known as twinning. And we help centers around the world to improve their capacity in treating children. And this program have progressed over the years, and we have realized that twinning and working with one hospital does not make a big impact. So now with Global Pediatric Medicine, St. Jude is working at a regional level, at a global level. We're working in collaboration with the WHO and several international agencies, so we make sure that we can reach to all the centers and we can have the most impact globally. We do this by 3 pillars. We train, educations, we build capacity by training and by improving the surgery, the pathology at the center. We assist in research, and research is not only clinical trial, it includes implementation science and quality improvement. And also, ALSAT, our foundation, assists the local foundation with advocacy and resource mobilization. And we have several tools to move those pillars in the region, because you can see this is the St. Jude Global Alliance, and we have partners around the globe. And to better organize that, we have the regional program, Mexico, Latin America, Sub-Saharan Africa, etc. So it's divided by WHO region that coordinate the work. And also we have the transversal program like nursing, leukemia, and those cross across all the region to make sure that we have standard of care that we apply to those region and to those centers. And again, we have the tools like a registry, we analyze the data, we review what we are doing, and we keep doing quality improvement so that we identify processes to improve our intervention and again, to scale what we are doing. So in order to help this kid in the center of the picture in the hospital, We need not only to help the hospital, we need to help the country, the region, and globally the whole world. And we need to work with the different partners. And at any time, we are working with all those layers. We don't forget the hospital, the needs of a special hospital in the region, but also we keep an eye on the big strategy for the whole region. And we try to create networks that communicate across all the region and learn from each other. Our collaboration with the WHO is helping us reach to the governments and to improve policy. Many of you on this call are participating in the GICC initiative for Cure All, and this has been a very important initiative that hopefully will revolutionize the outcome of children with cancer globally. So the question is, how are we going to address the gap in children globally? One answer is, in the past, people will bring the protocol we are using here and will apply them. And this does not work because when they did that, they had a lot of toxicity, they had a lot of abandonment because those protocols that we use were not tailored to the need of the population. So in order to narrow the gap, as I said earlier, we need to work in collaboration with those centers and assist them. I will give you an example. The first example that St. Jude started working with both the medical team and the foundation was in Salvador. They did not have an oncology program. They did not have trained oncologists. And in 1993, 90% of the children died from ALL. Over 10 years, we trained the physicians. We assisted them with starting a cancer care center. And within 10 years, the survival of leukemia went up to 70%, which is getting very close to what it is in developed country. And most importantly, now they have an oncology program that covers the whole country of El Salvador, and they have trained healthcare professionals. The same in Guatemala. You can see that between 1990 and 95, before we started the collaboration, the abandonment rate was 42%. The overall survival was 28%. So most of the children died from ALL, and they didn't have any hospital bed dedicated for children and no hematologist oncologist. When we started the collaboration with the hospital, government, and foundation over the period of 2000 to 2014, the abandonment decreased from 42% to 0.3 because the foundation and the social worker will follow the patient, they will assist them, and the overall survival improved from 28% to 65% because the treatment was modeled based on the country need. Now we are moving to adapting those protocols at a regional level, so it has more impact. So briefly, we have three main protocol ALL initiative in Mexico, 20 centers in one country, which is a large country. And then in the Eastern Mediterranean, 3 centers in 3 countries, and Latin America, in 5 countries, we have over 20 centers. What we do is we always do literature review. We discuss with our collaborator in the region, and we draft a strategy for ALL in a collaborative fashion. And after that, we draft the protocol with the objective. So one example is in 5 countries, Bolivia, Ecuador, Paraguay, Peru, and Venezuela. They got together. They formed the POLA for pediatric oncology in Latin America, and they have now they talk together to agree how to define low risk, intermediate risk, and high risk because they were speaking different languages in the different center. So they agreed on that, and we formed a table which is based on what they have, what their pathology allows. So you have in green the basic, which everybody should have the clinical assessment and the immunophenotype. And in the country that have the more advanced diagnostic, then they can advance their treatment. But while we are doing this, we are not only helping them to learn how to classify based on their capacity, but we are learning what their capacity is, and we want to help them to get the most specific diagnosis for their patient. So to bridge this diagnostic gap and have everybody have the more specific diagnostic, as I said earlier, in the countries where they don't have the advanced diagnosis, the flow and the karyotype, what we are doing, we are trying to have them, while we are training them on genetics and molecular, we are trying to move them to the molecular directly and skip the cytogenetics, etc., because most high-income countries are now using the molecular to stratify the risk. So we are training them to do that and to skip a lot of tedious steps that will require a lot of effort and then will be obsolete in a few years. So this is great for diagnosis and for treatment. But one problem, and that's the last few slides, is we have the treatment, we have the diagnosis, but we all know about the drug shortages. And the problem in the drug shortages is first the availability. It doesn't get manufactured sometimes. Second is the quality. Some countries do not get the right quality of drug. And of course, I discussed the cost. So to help with that, the WHO is working with St. Jude, and this initiative started in 2021. We are now in the pilot phase, 2023, with 6 countries. Ecuador is one of the countries in Latin America, and we hope to expand the pilot next year and then to go to the growth phase, to where, along with the WHO and the UNICEF, we provide essential medicine for childhood cancer in a way that we have all the steps organized, from getting them to shipping them to entry in the country, to adequate storage in the country, and to reaching place of destination without ruining the drugs. So basically, many advances are revolutionizing the way we diagnose and stratify ALL. All those innovations, in order to be applied to the whole world, requires collaboration and optimization so that every child anywhere can benefit from what we are doing. Thank you very much, and I will wait for the QA session.
Thank you very much, Dr. Sima. Dr. Sima commented first about the inequality that represents a place where children live with cancer in order to have a good outcome, being a less favorable scenario for those who live in low and mid-income. It has highlighted the importance of diagnosis with new methods that are precise and timely, which will help to guide the optimal and specialized treatment. It has shown how new therapies such as CAR-T and blinatumomab are superior in terms of survival, reducing side effects in the patient as compared with traditional treatments such as chemotherapy. However, and due to issues of cost, it is still a challenge for most of the countries globally. And therefore, so patients can have access to this specialized treatment. And this may represent an issue specifically for high-risk leukemias, which are more frequent in low and mid-income countries. It has shared this Youth Global Alliance, who works precisely to make that gap that prevent access to better treatment and diagnosis in the regions that require it. And for that, they promote the manufacture and drafting and develop of protocols tailored to their needs. And she has also mentioned about the global medication access for childhood cancer. Thank you very much, Dr. Sima. And please We will start with the Q&A session. Could you activate your video, please? The first question that we have for you is, I'm going to read the two questions. So the first one is there a greater incidence of childhood leukemia in mid and low income countries? From the local cases, what health determinants should be considered to reduce this incidence? And the second question is, how can we guarantee the quality of life of children and adolescents who survive leukemia? Thank you.
Those are very good questions. And thank you very much, Portly, for the nice summary you made for my talk, although it was very broad. So to answer the question, leukemia increase actually in developing countries, so it increase with industrialization. So it's not the incidence as much as the fact of the inequity. But then if it increases with industrialization, this will mean that probably it will be increasing in low and middle income countries as they become more industrialized. So this is a concern. But the two main concerns that I would like to answer this question is first, the leukemia and any cancer are underdiagnosed in low middle income country because there's no registries, no databases, and the patients are not referred. So we need to make sure to improve the system and to have registries so we do not miss the diagnosis and think that it's less common just because we're not catching them. And the second important thing is we have our pharmacogenomics group that's working with us to determine the subtypes and the predisposition, because as I mentioned, it's not only the incidence, it's the type of leukemia. And definitely in low middle income country, the high risk leukemia are more common than in the developed country. And it's very important to work on that. For the long-term survival, I think this comes after the patient starts surviving and the need becomes valid. But I agree that we need to be very careful with following the toxicity and preventing it, the acute toxicity. So first, prevent the toxicity acute and the abandonment, have palliative care for the children who need it and who are not doing well, and also start building long-term programs for follow-up.
Muchas gracias por las respuestas.
Thank you for your answer, Dr. Sima. Thank you for your presentation. We expect to continue collaborating with St. Jude in upcoming activities. Now, I will go to the next presentation. I would like to welcome Dr. Manuel Ramirez Orellana. Dr. Manuel is Doctor of Medicine from the University Autónoma of Madrid and a specialist in pediatrics and pediatric oncohematology. Did a postdoctoral stay at the laboratory of Dr. Kurt Sivin at Johns Hopkins, and later in the laboratory of Dr. Juan Bueren at CIMAT. He was a researcher in the Miguel Servet program until 2003, when he joined the oncohematology service of the Niño Jesús University Hospital. During this last decade, he has developed the cell therapy and gene therapy unit, the hospital, the oncohematology diagnostic unit of the hospital, and is responsible for the research laboratory of the oncohematology service. Now he will present the experience of leucodomics. Go ahead, dear Dr. Manuel Ramirez Orellana. The floor is yours. Well, thank you for the invitation and for the possibility of such an interesting presentation given by Dr. Sima. My presentation is about a research project that started at the beginning of this year. And therefore, I'm not going to talk about the results, but we still don't have them. But it's going to be useful for me to explain why do we think that this project may help in the future with the diagnosis and follow-up of children who have LLA. This is a consortium of groups of the Niño Jesús Hospital, of the Research Institute of 12 de Octubre Hospital, the National Center for Cardiovascular Research, the Biocomputing Lab and of the Mathematical Oncology Laboratory from the Castilla de la Mancha University. And the idea is that or the summary is that we want to integrate everything that we consider, the amount of information at different levels that are associated to any patient who has childhood leukemia, in this case, the ALL. And for that, we're going to review what are the sources of information that we are managing. We understand that a child who is diagnosed with leukemia comes from a process of months or years that starts by a concept that can be called susceptibility to develop this disease. And this susceptibility may be inherited, genetic, up to a 10% of children who have cancer. We have discovered that there's a genetic susceptibility in the germinal line, but it may also be acquired. The issue here, or the idea, is that that is not the only thing that they need for having disease. There are many things, other things that are needed. And from that first event, and that is something that we're going to see about months, years in the life of this child, and it will transform a cell that is pre-leukemic into a leukemic cell that then is going to produce the disease that we diagnose and treat. How do we diagnose? Well, some things have already been mentioned in the previous presentation. There are many tools that can help us diagnose leukemia, especially, of course, morphology under the microscope. But now we have flow cytometry for many years that allows us to see markers that the malignant cells express in the membrane or inside the cytoplasm or nucleus, and allow us to identify those cells and start to give them their last name to the issue. Also, issues with the structure of the genomic of the chromosomes of that cell with the cytogenetic are very important when we diagnose this. We have aspects that have to do with clonality of that cell proliferation that are studied by molecular biology techniques, and more recently, as you know, we have started to add massive sequenciation that these malignant cells exhibit at the time of diagnosis. And with all of this information, which is intrinsic to leukemia in children, we know that it is important, as it has been underlined by Dr. Hija. We know, and for a long time, we knew that there are leukemias that have a cytogenetic associated with a good response to treatment, and those are agents with a low-risk leukemia, such as the translocation RANS1s or leukemias that have high hyperdiploidy. There are others who have some cytogenetic abnormalities associated to a poor response to treatment, and that is the group of low risk. And in the middle, we have other leukemias that we decided to call them intermediate risk because they didn't come when one or the other side. And in this group, in addition to translocation, TCF3 and PBX1, there was a group that we call the others B. The others B, with the technology that is now being developed, we start to see groups that are defined by cytogenetic abnormalities that were not recognized before. But then we go again to the same story. Some of these new entities that have a poor prognosis and others who have a good prognosis. The concept of good, intermediate, or poor is within the approach to childhood leukemia. Because in this slide, or that was previously shown by my colleague, we see that the likelihood of surviving depends of that genome structure of those cytogenetic variations or abnormalities. So another aspect, in addition to what I just comment, that we need to consider when we diagnose this disease, if this leukemia is colonizing when it's diagnosed in the central nervous system. Because we know that this lymphoblast like the central nervous system. And if we know for several decades in their cells, it's mandatory to do a lumbar tap to see that if the time of diagnosis this part is affected. And these are different levels of information that we integrate on the day of diagnosis to decide what type of leukemia we have in front of us, and in the sense that if there are any chance that can be cured with an intensive treatment. So we place our children at risk groups. This is a slide that shows a schedule that we use locally, but it can be compared with international protocols. Children are classified, we call the low risk or standard risk, but children that's less intensive than those who are in the high risk group. And the location or one of another group depends on the clinical biological information that we have obtained. Once the child starts to receive treatment, the important issue is to see at what speed the disease is cured with the treatment that is being administered that is adequate to the diagnostic information. So it's very important, and we know this for several decades, that we need to quantify at a very specific moment of the protocol how much residual leukemia we have in the bone marrow of the child. We use flow cytometry methods and molecular biology to provide a residual disease. And this information that I'm sure that it reflects a different biology can only be obtained during treatment. It cannot be obtained at the time of diagnosis, but it has a prognostic impact that's very significant. We can see in this comparison of survival published in 2015. All this information is just to have in our heads that in recent years, the improvement in outcomes of the different treatment protocols that the cohort of children have been receiving, and this is a slide from 2015 that Dr. Yija have shown the experience in St. Jude, the adding of the knowledge generated by the study of the clinics and the biology of leukemia resulted in treatment strategies based on chemotherapy, most of them, and now we have other new modalities that have improved survival significantly, but not 100%. So we in the field have a number of them. And I would like to point out some that we consider have designed our project. We know that survival has not improved that much any cost. To the right, you see a photo of two sisters. One is a long-term survival of ALL, but following the toxicity that we provided in the 80s, is a woman who being twins, is a low overweight, and it has a low height, and they also have some neurocognitive. That is a challenge for the pediatrician who treats these children. We need to cure all and without any long-term delay. Another that is a challenge for us in children between 15 to 20% relapse after therapy. And that a challenge at several levels, but when you look who relapse, most of children who relapse are those that we have to according to what we call intermediate risk. And that has to lead us to think that that group is a potpourri of children that are not well diagnosed. Surely, many of these children would have been treated with a protocol of high risk because they're actually leukemias that are not well diagnosed because we lack knowledge. Another challenge, and this is a work from the group of St. Jude of 3 years ago, when you bother to look those relapses, one may think that the re-emergence of this that I diagnosed years or months ago, well, actually, when you study it in detail, the response is not that simple because what you find in relapse, in very few cases, but it may happen, it may be the evolution of a pre-leukemic cell that was not considered in diagnosis, or it may be the entire complex of clones that diagnoses that leukemia. This is a minor clone in the diagnosed, but now it has grown during the relapse, or maybe the evolution of clones that were considered at the initial diagnosis. So this just indicates that relapse is not homogeneous. Something that we know in the diagnosis, but it's not that known for relapsing. We want to improve relapses, we have to use this knowledge. And finally, another challenge that I understand in terms of research, we have looked in what are the malignant cells, hematopoietic malignant cells, and we're not looking in detail at the research level in the environment that these cells, hematopoietic cells, become leukemic. The environment where these malignant cells fight against chemotherapy, the environment they relapse. This knowledge that is lacking has to be generated. With all this production that I've shown you, we got together to see what can we do to contribute from research side before applying it to the clinic, a preclinical translational research. So as it has been suggested by Dr. Yiha, the improvement in the outcomes have come by adding the knowledge learned by technology. And technologies in the management and interpretation of scientific data have recently improved significantly, and now we can integrate many layers of information from several entities that in the digital environment reproduce the situation or the clinical biological situation. And the leukotomics project is just an attempt to apply all of this in lymphoblastic, acute lymphoblastic leukemia, because I have tried to show we generate, well, not us, patients per se, in the studies that we do to the patients in the malignant cells, that generates a lot of information that may be integrated in what we call digital models. What leucotomics is want to do. Why do we want a digital model in a child with leukemia? In order to make a digital research for situations that are present in the clinic, that can be seen in the clinic, and we can anticipate to aspects of prognosis and therapy. And for that, we have developed a project in which we're going to collect data from 100 children who have been diagnosed and treated. This is a study, a retrospective study at the beginning, clinical data, several known phenotypes in childhood leukemias, in adolescent leukemia, has been diagnosed and treated in our hospital. And that information, and we have primary samples in a biobank, and we're going to be able to do individual cell sequencing to study the genetic of the malignant cells as well of the healthy cells of those children. And our physicists are going to study those cells that are not being considered so far, and that have to do with biomechanical characteristics of cells, temperature, degree of entropy, and this. So with all this information that's clinical and genetic and cytogenetic and biomechanical, finally, it's going to be created in mathematical models that would allow us to generate. Mentioned this is a consortium because we need several experts to approach quite a bit. So we have these research groups that I'm presenting to you, where each one of us has a profile. Ours is more clinical, logical, partners who are experts in bioinformatics to the information generated by sequencing. We have two partners that are biophysicists, and we also have a node for mathematics who apply this knowledge to the study of data of patients. So to conclude the circle, close the circle, this is what leucotomics. These are components of the consortium. These are going to be their tasks. And our final goal is to generate this for these children, and based on retrospective data, a digital twin where we can experiment, ask questions, adequate questions, both individually as cohorts also will allow us in the future to head to the but this would be the first major phase of leucotomics, because we expect that once we have these digital twins, we could validate them in a prospective study. But that's something for the future. We expect to start generating data at the end of this year, how 2024 complete that, and end the year with the first digital models for this cohort. And this is the information that I wanted to share with you. I understand that this is a research project, and therefore there's its own risks and level of knowledge, but it will grow year after year. Thank you very much. Thank you, Dr. Manuel, for your presentation. Dr. has mentioned the Leucodomics project, which is a precision medicine project for ALL children And he has indicated that this project is given in a concept that although there's been progress in treatment and diagnosis, has been reflected in a major survival of children with childhood cancer. There are still challenges, approach of sequelae, prevent relapses that may be related to an process. He told us that there are certain in paths to cure that perhaps not receiving the adequate attention, and there is where this project leuconomics comes in, the use of technology or the management of scientific data allows replicate case of leukemia at digital level, and this digital twin, as it has been called, twin, or through this digital twin, it is possible to test scenarios and do simulations of what will be the response. This initiative, as you mentioned, requires specialties such as biomechanics, bioinformatics. That is an initiative that will provide excellent results, and where the most important goal, as Dr. mentioned, is to provide better survival, avoid relapses, increases the side effects, and the use of technology. So now we'll go to the Q&A. Thank you very much, Dr., for your presentation. One of the first questions is the following. If we can achieve the use of technology in the future, do you think that this will generate a significant increase in survival and quality of life? What challenges can you with this initiative?
Pues el tema de los gemelos digitales que se están desarrollando,
digital twins that are being developed, but there are many other colleagues that are developing digital twins in other conditions. And the point is that this tries to be an additional instrument for the doctors, the physician. The limitations that we have are those related to the technology, because they demand a lot of data, so the approximation is sufficiently good. What I see here, like 20 years ago, when we had a cassette for the radio for music, which the young people in this audience don't know what it is, but then we move on to other reproduction for music, and now nobody has at home a cassette player or a CD player. We all can listen to music with our mobile phone. I see that in the future, on one side, the way that we generate will increase, and also the way in which physicians do this instant use during their outpatient, when they see patients and use these digital models, is going to be. How long is it going to take? Well, actually, I don't know. But technological development that has to do with information technology, in terms of 5 years, have witnessed unthinkable increases. I think that this next decade is going to make this technology available to patients. One question, if you can comment about the experience in Europe or Spain, what is the role that this these computerized or digital health systems play a role because they're still a challenge for low and mid-income countries. That's perhaps it's a first step to for work with this project because our countries are still lacking this digital health system. You tell us about experience in Europe or Spain. Well, what I can comment is our local experience, but it reflects other developments. Our hospital was not a pioneer, but the electronic record that was provide digital support and to replace the conventional manner that we used to write down the clinical record and keep it in files and to look at the x-ray. That has changed in the last 5 years to interaction through the mobile phone or the laptop, and that facilitates the work of the doctor. In the future, we're also going to see in this context of a tablet or a laptop or a mobile that will support the pediatric oncologist work with applications that would interpret images, for example. All that is going to be added to of low or mid-income that sophisticated diagnostic technologies, because it may be more difficult to have a massive sequencing in a remote area, for example, in the southwest of Spain, where I come from. In my town, everybody has a mobile phone or a tablet. So that type of experience tells you that this may be more easy, this technology for medical information analysis are more easily interoperable than other sophisticated methods such as. So I think that this is going to be more feasible. Thank you very much for your excellent. We invite you to stay in the room if you have the time for a final end of the presentation. Next presentation, we invite Dr. Arturo Zapata Lopez. Dr. Arturo Zapata Lopez is graduated in medicine in 2010 in Ricardo Parma University, Lima. He completed pediatric training in 2014 at the Universidad Nacional Mayor de San Marcos in pediatric oncology at Universidad Peruana Heredia. Sir in epidemiology, statistics, also global health. Dr. Zapata currently works as a pediatric oncologist at the National Institute of Neoplastic Diseases, where 65% of childhood cancer patients in Peru are treated. In this opportunity, Dr. Zapata will talk about RT, achievements, limitations, and opportunities. Welcome, Dr. Zapata. Go ahead, you have the floor. Hello, everyone. I'm going to share my screen. Thank you for the invitation. We're going to, in these brief minutes, in general comments, mention the CAR T cell therapy, but I would like to start by showing this graph that has been shown by the previous speakers, where the message is that treatment of ALL, despite the years past, field based of conventional chemotherapy. Although it is true, as you can see, the survival curves have been improving with the protocols, treatments, and support and reduction of abandonment and introduction of new drugs. The treatment or the message is that most of ALL in children should be cured. So this survival curve, the different studies that and in youth, that I'm sure Dr. Sima has showed, is that in the best scenario, today ALL in pediatrics has a survival greater than 90% of severe follow-up. This image, just to mention that even as the previous speaker mentioned, there's a number of patients that have the risk of relapses, that's close to 20% of patients with ALL. But in this scenario of relapse, conventional chemotherapy still has an important role, especially in scenarios of low and mid income, as happens in Peru. You can see that we have protocols in the UK, known as the UK LLLR3, who has a figure survival, a PFS close to 65%. German protocol ALLRES has a similar survival, or protocols that include more novel therapies such as blinatumomab with 60% survival. They're quite similar. This image also helps us to look at the scenario because although it is true that patients with a relapse have a less favorable diagnosis compared to those who have a early onset leukemia, not all the relapses have the same approach. The relapse determinants depend on the type of leukemia. ALL is a general term. We know that there are several subtypes, and it will depend on the type of treatment that has patient previously received, and it will depend if there's any genetic abnormality that requires a targeted therapy. It will depend on the type of relapse. One who has a relapse only in the bone marrow, or one who has a relapse on the testicle, or somebody who has a relapse both sides, or nervous systems and spinal cord. It will also depend on the timing of relapse. Not the same a patient who has a relapse during the 2 or 3 years after treatment compared to a patient who has a relapse. And why there's some papers that try to classify relapses in risk groups in order to define the approach for even to that patient. And in this particular case, this novel therapy with CAR T cells a role or would be an option for those patients who have high risk relapse or refractory treatment. We'll talk about that. Who are those that we consider or consider to be high risk relapses? It's going to depend on the pediatric oncology group that we study. Those globally have divided into trends. North American, that we have the children oncology group that considers high risk relapse those who have a relapse but BALL that's early, 36 months in marrow, or a combined relapse or extramedullary bone marrow, or the European, which is the BFM, with high risk relapse is the one who has early that occurs less than 18 months since the time of diagnosis, and those who have a combined relapse.
denominada hace referencia a que hay dos o más lugares comprometidos
two
en
or
la
more
red.
places that are involved in this relapse that may be the spinal cord or the bone marrow, the testicle, or the nervous system. So going back to the quantification, as I mentioned, the first message, that more than 90% of patients with ALL in pediatrics should be cured with the first treatment, which is conventional chemotherapy. But conventional chemotherapy is not a solution for all patients. It has been seen. So the trend is that despite increasing the intensity, which is one of the strategies provided by some risk leukemia groups, reaching a level of tolerance. Therefore, current research are trying to add novel treatment in certain groups of patients in order to increase survival and decrease, not increase patients and those patients, know those patients who have relapse or are refractory to these options or novel treatments is immunotherapy. Immunotherapy in general for pediatric leukemias, we can divide it in two large groups. We have the antibody-based therapy, blinatumomab. That is not part of our presentation. The other group is the T-cell-based therapy, the CAR-T, that we're going to talk now. In order to provide some historic context, that this is not an old treatment. This is first approval for pediatric population in 2017. Is drug now Kimria, which is a type of CAR approved for very specific cases of relapse ALL, children or refractory ALL. And I say this type because CAR T cell involves different drugs that have been developed and other that are under development. So this not a single. When we talk about CAR T cell, we have to consider several phases. One phase, we extract the T cells of the patients that are part of the immune system. They extract these T cells, they take them to a lab, and they do a re-engineering through viral vectors, virus or retroviruses, to stimulate this T cell to produce or generate these chimeric antigen receptors in order. So then we will have a proliferation of these T cells that are trained, quote unquote, and then administer them back to the patient, and they can do a specific identification of cancer in this particular case of those leukemic blasts to eliminate them or kill them. So this is a type of therapy that requires the patient's defenses, which are the T cells. So in ex vivo, in a lab tube, we can remodel them, then able to identify certain surface antigens of this leukemia in particular in order to get rid of it, kill it. That is why this technology called CAR T cell can be generated different oncologic problems, different leukemias, or even other types of malignant cancer neoplasias. Because it will depend on the type of cell or the surface antigen that the cancer has, the one that we want. This of collection of T cells. Patient monoleucophoresis involves a logistic that you can see where you need in order to observe and transport, take them to the lab to do this processing of re-engineering, where we're going to induce these cells of the patient, send these genetic receptors, antigens, then and administer back to the patient the treatment. So specifically, CAR T cell that has been approved for pediatrics, which is a Kimbria. This is a T cell that is trained to identify the CD19 surface antigen, which is one of the markers that are representative of the blast of ALL. The property of CAR T cells, opposed to chemotherapy, they can migrate and reach areas such as the central nervous system, or they're classically considered sanctuary organs, or organs where conventional chemotherapy doesn't penetrate frequently, are areas where there's a highest risk of relapse. That's why the CAR T cells can also have a role, that's a significant role in those patients who have relapse outside the bone marrow. Also been described as CAR T cells positive effect on relapses because lead many patients to remission and disease control, but it has been described that it's not been that prolonged. After 18 months of administered, they lose their effect, and that makes that the patient is susceptible of a relapse. As any medical treatment, it has adverse effects, and the most feared ones are a cytokine release syndrome, which is a systemic inflammatory similar to a sepsis state, and neurotoxicity or neurological effects that occur during the first month or 8 weeks after the start of treatment. And we also consider it a treatment that has not received a role, given that many reports it's been described that they may lose their effect. So it can be in some scenario considered a bridge as an early treatment after, before we take the patient to a definitive treatment as an HCT. And that is a question that's still in debate, of this type of treatment or a technology that is relatively recent. Here I mentioned this study known as the Eliana study. Is one of the most relevant studies in pediatric patients. As you can see, in a 12-month follow-up, with this CAR T cell trained to attack cell blast, obtain a remission rate of 80% in patients who relapse, which is a very high and promising rate. And in the 12-month follow-up, an OS of 70%. But when we have followed them, the survival falls, and it's still under discussion if the CAR T cells would be an alternative for definitive treatment for patients who have relapsed or have refractory disease, or they may just be a bridge treatment to maintain the patient in remission or to take the patient to remission, and then offer a definitive treatment such as stem cell therapy. So you can see, as I mentioned before, a cell that's considered the one that blast, a B blast or a T blast, regardless and or depending on the phenotype or the type of blast, this is going to express some surface antigens or clusters of differentiation. In the case of E leukemia, it may express this surface antigen or CD19, which is this one of the most studies where the CAR T cell the one
o reconoce
who
para poder
recognizes
diseñar esa célula, ¿no? Pero
for those
también
cells,
como se diseñan CAR T-cells para que
and
reconozcan
CAR T cells to
antígenos de
recognize
superficie CD19, pues también
CD19,
se han diseñado otros CAR
and they
T-cells para
also design
reconocer
other
otros tipos de
CAR T
antígenos
cells to recognize other
específicos, ¿no?
type of
Pero
surface
el
antigens.
más conocido o
But the
el que se
most
tiene más
known,
experiencia hasta ahora
or
con el
the ones
tiempo,
with more
es el que
experience,
reconoce
is the one that
CD19.
recognizes CD19.
Como mencioné también, las
Mention
toxicidades tempranas, aquellas
the
que
early
ocurren en el
toxicity,
primer
those that
mes
occur during the
para
first
el
month.
síndrome
We're going to
de
find
elevación de citoquinas,
the
se comporta como un síndrome
cytokine
de
release
respuesta inflamatoria
syndrome
sistémica.
as a systemic
También tenemos
inflammatory
la
response.
neurotoxicidad
We also
del
have
CAR T-cell, que
neurotoxicity
habitualmente
that
regresiona, pero también en
there's a
ocasiones
regression, but in
puede
some
quedar con
cases the
alguna
patient may
secuela, ¿no?
be left with some
Entonces,
sequelae.
al ser una terapia
So
novedosa
by being a
y
novel
requiere de mucha
therapy and
tecnología
require a lot of
para
technology,
poder diseñarla y luego
and then
administrarla,
find it and
hay
administer
algunas
it.
limitaciones en países que se encuentran en vías de
So
desarrollo
for
como el
some
nuestro.
developing countries such
No
as
hay esta
ours,
tecnología no solamente
what
para
the
desarrollar
technology not only to
o
develop
desarrollar a este linfocito T,
this
sino
T
también
lymphocyte,
por las evaluations
but
previas que
also for
requiere el
the
paciente y
evaluations that the
también
patient
por
requires
el monitoreo que se le tiene
and
que
the
hacer a
monitoring
este
that the
tipo de
patient
pacientes,
needs to
¿no? Como
for
hay
this,
una
because
producción de
there
citoquinas
is a
en el cuerpo del paciente, hay que
production of
monitorear
cytokines
algunas
in
de
the
ellas
patient. We need
que
to
estarían
monitor
interleuquinas
some of
6
them,
para ir
among them the
prediciendo si el paciente va
IL-6,
a presentar
to predict if the
alguna
patient is going to
complicación
show
luego del
any
tratamiento. Lo otro es la
following
logística,
treatment.
como vieron,
We also
hay
have the
que
logistics
extraer las células del
to extract
paciente,
the patient
llevarlas a un
cells,
laboratorio,
take them to a lab
criopreservarlas,
with
llevarlas a administrar,
cryopreservation,
y
and
todo
then
eso implica una
administer, and all of
coordinación
that
o una
implies
logística, ¿no? Los
logistic and
costos, como son
coordination.
tratamientos modernos
Costs,
que
because these are
requieren,
modern
son
treatments that imply
costosos,
technology, are very
y
high
eso también
costs.
se convierte en una
That also
limitante
becomes a
para países como el
limitation.
nuestro. El
Ours,
soporte, como mencioné también,
the
no están exentos
support
de reacciones adversas que
is
pueden llegar
required
a ser
because there are
severas en
some
algunos
adverse
casos
reactions that may be
y eso
severe in
podría
some
requerir
cases and
algunos
may
tratamientos
require
específicos para
some specific
controlarla,
treatments to
incluso
control
con
them,
drogas que no disponemos en este
and
momento
drugs that we
de
don't have
desarrollar
available at this moment in
y
our
requerir
country,
también de manejo y
and also
entrenamiento
may require
para administrar el medicamento, ¿no? La disponibilidad de
management and
tratamientos
training to
complementarios,
administer this
porque como
treatment.
también les mencioné, hoy en
And I
día
also mentioned
todavía no se ha terminado
we still have
la
not
conclusión
finished
definitiva con
to
el rol de los CAR
have
T-cells,
a defined
porque para algunas
conclusion about
personas
the CAR T
muy
cells,
corrientes o para algunas
because for
publicaciones,
some groups,
los CAR T-cells podrían
the
ser un
CAR T
tratamiento
cells
o
may
un
be
puente
just a
a,
bridge
a
therapy
llevar al paciente a un trasplante
to
y si en algunos países no se dispone de estos
transplantation.
trasplantes,
In some countries don't have
¿qué
this
podría
transplant
ocurrir en esos
available.
casos? ¿No? O sea, tendría que haber una
So
logística, tendría que haber
this is
una
require
red
logistics,
en la que se
a
pueda
network
a nivel regional
where
coordinar
at
para
the regional
garantizar
level
que
we
los
can do
pacientes
coordination
tengan
so
un flujo
and have
adecuado
an
y en algunos lugares donde no se
flow, and in
disponga del
some cases
trasplante
where we don't have transplant
definitivo se
available,
pueda enviar a otra
we could
institución o
refer them to
regional
another
para
institution or
poder
another country
ofrecer el mejor tratamiento
for
posible a
the
los
best
pacientes, ¿no?
possible for the
Y la
patients.
capacidad del
And
país o de la región,
the
ya que
follow-up
al ser
capacity of the country or the region
un modelo de tratamiento que
by being a
involucra
model
bastante
of treatment
tecnología,
that involves
es importante
quite
tener
a lot of
el
technology,
respaldo de
important to
instituciones con
have
experiencia
the
previa,
support
¿no?
of
Para que
those with previous
se
experience
genere
in this area
experiencia también
so
local,
we
¿no?
can generate this local
En
experience.
conclusión,
So in conclusion,
los CAR T-cells son un tratamiento novedoso,
are a
pero
novel
no es un
treatment,
tratamiento
not
único para la
a
leucemia en situación de recurrence.
single
No
treatment
tiene
for leukemia
actualmente
in relapse
aplicaciones muy
situations.
puntuales y
That's
algunas
very
otras que se
precise
están explorando,
in
pero no es una
applications,
opción
but it's not
única, es más bien una alternativa o una opción más a la que ya se
only
dispone
one more
actualmente.
alternative that we have available
Prometedora
today.
sí, pero sigue siendo una
Promising,
opción.
but it's still just an
No se
option.
ha definido todavía el rol
We have not
si
defined
sería
the
un rol
role if
definitivo
this is a
o si requería algún
final treatment or
tratamiento
if it requires
como un trasplante
some
posterior. Eso
treatment
obtendremos
such as
respuesta en los próximos
transplant.
años,
And we will
pero
learn
la
about that in coming
importancia de
years,
la
and also the
descentralización
importance of
para poder
decentralization
producirlo en algunas
of
regiones
production.
de medianos ingresos. No,
So
hasta donde tengo entendido,
as far as
en
I
algunas
understand,
revisiones que hice en Brasil
in
y en México,
Brazil and
ya hay
Mexico, they have
algunas iniciativas para
initiatives to
desarrollar sus propios
develop
CAR-T
their own
directamente
CAR-T
con
cells
el apoyo
locally
de
with
las
the
operaciones
support
internacionales.
of international
Entonces, eso es
collaboration.
lo que yo tenía preparado
This
por
is
el día
what
de
I
hoy.
had prepared for
Muchas
today.
gracias y quedo atento a sus
Thank you
preguntas.
very much,
Gracias.
and we're ready for any Q&A.
Muchas gracias, doctor Zapata, por
Thank
su
you, Dr.
presentación.
Zapata, for your
El doctor
presentation.
Zapata nos menciona
Dr.
que el
Zapata
90%
mentions
de
that
los casos
90% of
de
cases
leucemia
of
linfoblástica
pediatric
aguda
ALL
podría mejorar con
should
quimioterapia, que
improve
es el tratamiento tradicional.
chemotherapy, which is a
Sin embargo,
treatment.
existe un grupo que
However,
requiere
there is a
nuevos
group that
tratamientos,
requires
como la
novel treatments
inmunoterapia.
such as
En este
immunotherapy.
caso, la exposición se
And
ha basado en el
this
tratamiento
was
con
based in
CAR-T.
the treatment with CAR-T.
Sobre el CAR-T, quiero
Regarding
mencionar
CAR-T,
las fases del tratamiento de
I
manera
would
muy
like to talk
resumida.
about the different
El doctor
phases of
nos
treatment.
menciona que se requiere
And the
primero
first, you need
de
to
la recolección de células T del
when
paciente,
T cells
trabajar estas células
work
rápido en
these
el
cells
laboratorio,
at the lab,
reproducir las células, se
reproduce,
administran luego
and are administered
las
back
células al paciente y
to the
estas
patient.
células
The
CAR-T
CAR-T
reconocen y
cells
se unen a las
recognize
proteínas
and bind to
específicas de
specific
las células
antigens
cancerosas
of the
y las
cell
tratan
and
de manera muy puntual
them.
a solamente a estas células, ¿no? Al ser una terapia
By
específica,
being a
el
specific
CAR-T
therapy,
puede ser un tratamiento adecuado,
mentioned that
sobre
this may
todo
be
para
an adequate
casos de
treatment for those
recaídas,
cases that
que
relapse,
si bien es un nuevo
that although
medicamento
it's a novel
con una gran
therapy
posibilidad de
with a
sobrevida y
major
gran
opportunity
éxito,
for
como
survival
otros
and success,
medicamentos, efectos
as any
adversos
other
a considerar. Y
medication
aquí
has
sí
some
traigo a
side effects to
comentario la
consider.
importancia
And
en
here we
casos de los
shown
estudios como los que
the
se han
studies
mostrado de
such as the
leucodosis
ones
y
he showed
en indagar en posibles escenarios, por ejemplo,
to
de manera
study different
digital,
scenarios of the
y adelantarse
leuconomics.
a una adecuada respuesta. Nos menciona que
He
entre
mentioned
las
that
limitaciones,
be-
los temas
among the
logísticos que implican
limitations,
la
the
utilización de este
logistics issues
medicamento, ese sería el principal
would
reto
be the
para los
production of
países
this
de
medical
bajos y medianos
challenge for
ingresos.
low and mid income countries.
Muchas gracias, doctor.
Thank
Tenemos
you,
algunas
Doctor. We
preguntas.
have some questions for
Nos
you.
han llegado muchas felicitaciones también por la exposición.
Have a lot of
La primera pregunta
questions here. The
es,
first one,
¿qué investigaciones adicionales
what additional
son
research do
necesarias
you
para
consider are
mejorar el
necessary
éxito de la
to
aplicación
improve
de la
the success
terapia de
of
CAR-T?
the use of CAR therapy?
Bueno, todo paciente
Well,
va a recibir este tipo
all
de
patient that is
tratamiento
going to
debe
receive this
ser, en
type of
primer lugar,
treatment should first
seleccionado o
be
evaluado por un equipo de
selected and
expertise,
evaluated by a
ya
team with
que,
experience.
como mencioné
Because, as
anteriormente,
I
no
mentioned
están
before,
exentos de
it
complicaciones.
is not
Entonces hay una
devoid
evaluación
of
basal que se
complications.
hace
So there's a
al
baseline
paciente
evaluation that we do
y si
to
el
the patient.
paciente tiene
And if the
un
patient
tipo de
has
recaída,
a type of
¿no?
relapse
que calza, ¿no?
that fits
para ser seleccionado,
for
¿no?
fits to be
Luego
selected,
de ser administrado estas células ya
after we
entrenadas, ¿no?
administer
Las
these
propias
trained
células leucémicas
cells
ya entrenadas por
that are trained
ingeniería,
by
hay
this
que hacer un
engineering,
monitoreo de marcadores de
we need to
inflamación,
monitor inflammatory
entre ellos
markers.
está la proteína C
We
reactiva,
have
la proteína C
C-reactive
interleuquina,
proteins, some
interleuquina 6,
interleukins such
¿no?
as
Que en
IL-6,
algunos casos ayudan
that in
si
some cases they
si
will
el
help
paciente va a desarrollar en las
if the
próximas
patient is
semanas, luego de
going
haber sido
to
infundido estas
develop
células,
in the following
un
weeks
síndrome conocido como el
a
síndrome de
syndrome known
activación de
as
citocina,
the
¿no?
cytokine release
Que es
syndrome,
similar a un síndrome inflamatorio
similar to
sistémico donde está
inflammatory
generando una
syndrome.
inflamación
So these
que
mediators
habitualmente se produce en el
inflammation
cuerpo en
that are
cantidades
usually
controladas.
generated in the
Digamos,
body in
frente a
controlled
una situación
amounts
de agresión, una
when we are
infección,
facing
un
an
estado de
infection
sepsis.
or a
Entonces,
sepsis.
en este caso, hay una
In this case,
reactivación
there
del
is a
sistema de defensa
reactivation of the
provocada, ¿no?
immune system that is
Voluntariamente
triggered,
por nosotros con la
voluntarily
intención
triggered
de
by us.
estimular
We want to try
ataque
to
a estos blastos
stimulate
leucémicos,
a better attack to
puede
this
también
blast, may also
estimular
generate
hipertensión,
states of
estados
hypertension
similares al de una sepsis
similar to
severa y
those
el
of
paciente
a
incluso
severe
puede
sepsis.
terminar
And
en el
patients may
ICU,
even
¿no?
end up in
Y
the
requerir el
ICU
soporte
and
que
require
esto implica, ¿no?
supported
Entonces es por eso
supplies.
que
That is why
es complejo y retador
it's complex,
diseñar esta terapia
challenging
en
the
países
design
con
of
pocos
this
recursos,
therapy in low
no
resource
solamente por la
countries,
tecnología
not
que
only
implica,
because
sino
of the
también por
technology that it
el
requires,
soporte que necesita luego
the
de ser
support that they
administrado,
need after administration.
no solamente para manejar las complicaciones
not only to treat
para
complications,
realizar estudios de
also to
monitoreo.
carry out monitoring.
Sí, excelente. Y
Excellent.
una pregunta adicional.
And an additional
Comentarios.
question.
¿Se podría decir que las
We
niñas,
say
niños y
that
adolescentes de
adolescents
Latinoamérica
and
son
children in Latin
genéticamente
America
predispuestos a
are
cáncer?
genetically
¿Qué
predisposed
rol
to
tienen
cancer?
las múltiples
What is the role
enfermedades
of
infecciosas,
multiple
la
infectious
anemia, la
diseases,
desnutrición,
anemia,
aparte de la
malnutrition,
posibilidad de
in
acceder a
addition
los
to the
modernos tratamientos?
lack of opportunities
Sí,
to access to modern
es
treatments?
una muy buena pregunta y una muy buena
Well, this
observación.
is a very good
Eh,
question and
no ha
observation.
sido motivo de la charla, pero
It's
se
not
podría
part
decir
of my
que
presentation, but what I can
países de
say
ingresos
is
bajos,
that in low income or
como
mid
muchos
income
países de Latinoamérica,
countries, such as many
eh,
countries in Latin America,
muchas veces tenemos el concepto de que
we have
la
this
garantía,
concept
la mejor posibilidad de curar
that
un
the best
paciente
possibility to cure
es
a
el
patient
tratamiento, ¿no? Y eso es
is
verdad.
treatment,
La
and that is
terapia
true.
es parte
Chemotherapy
fundamental
is an important
para
part
poder llevar a un paciente a controlar su enfermedad y
to
posteriormente
control
su
the disease
remisión.
and cure.
Pero hay otras situaciones que son
There are
importantes
other
como,
important
por ejemplo,
situations
el diagnóstico
important to
temprano,
consider, such as
el
early
diagnóstico
treatment,
oportuno. Para eso implica un poco de
and for that
educación,
implies
que los
education,
sistemas
awareness.
sean
Health
organizados,
systems
¿no?
need to
Que
be
existan
organized,
niveles de referencia
have
fluidos, que
fluid
exista
referral
capacidad
systems,
diagnóstica, ¿no?
diagnostic
Pero también es
capabilities.
importante el
But it's
soporte,
also important
que se
the
pongan pues,
support
los
to
antibióticos,
have good
camas
antibiotics,
intensivos pediátricas,
the
que pueda haber un buen soporte
PICUs,
con
and to
transfusiones, porque
have
los niños con
support
leucemia
with
necesitan
transfusions because children with
requieren
leukemia
soporte de
are going to
transfusiones.
require
Entonces,
transfusion
para
support
reducir a lo más que se pueda que el
to
paciente pueda
reduce
pues, tener un
the
desenlace fatal o
possibility of
fallecimiento por
a
causas que son
poor
prevenibles.
outcome of the patient
Es
for
un
causes that
poquito
can be
anecdótico. A
preventable.
veces el
For
paciente
example, that they don't
tiene
abandon
diagnósticos
treatment.
oportunos
Sometimes the
por
patient is
razones
going well, but due to
sociales,
economic or social or cultural or
abandona el
geographical
tratamiento
reasons, abandon
y no
treatment.
recae porque el tratamiento
They
fue
have a
inefectivo,
relapse, not because of
probablemente
a poor treatment,
no
but
continúa el
relapses because
tratamiento, porque a veces se asume que
they did not
va a
continue
haber una
treatment.
segunda o tercera oportunidad de
Sometimes they
recuperación y
think
muchas
that
veces
there's a
no es
second
así,
or
¿no?
third chance
Y
for
en ciertas
recovering. That's
enfermedades
always the case.
también existe un factor importante
But there's
que
also
es
an
el
important
factor
factor,
genético que está
a
mencionando.
genetic factor you
Entonces,
mentioned.
se sabe y se conoce
It is known
que no es lo mismo un niño
that
con
not
leucemia
the
en
same
Estados
as
Unidos
child with
que en
leukemia in
Europa
the
o en
US, in Europe,
Latinoamérica.
and in Latin
Probablemente
America.
mucho tenga que ver con el
Perhaps it has
mestizaje.
to do with
Y hay datos publicados
isotype.
que la
There's
población
published data
latinoamericana
that the Latin American
tiene una
population
característica muy particular de tener una
are
mayor
characteristics of
prevalencia de leucemia
having a
linfocítica
higher
de alto riesgo,
prevalence
¿no?
of high risk
Y una
ALL.
de las posibles explicaciones
And
pues
one of
es
the
este
possible explanations
componente
is the
étnico que tenemos
ethnic
muchos de
component
nosotros, ¿no? Que
that
hace
we all
que
have that makes that
tengamos una
we
predisposición
have
mayor a
a
tener
higher
desarrollar más
predisposition
enfermedad
for
que se puede
more
volver
aggressive
irreparable en el
leukemias
mundo. Con
compared to
respecto
other
al
areas of
tema
the
de las
world.
infecciones,
With regards to
realmente existen muchas
infections,
teorías del
there are
cáncer. Se
many
podría
cancer
decir
theories, and what
que el
I can
cáncer
say
en niños tiene una
that
biología
cancer in
y
children
comportamiento muy
has
diferente
a
al de
very
adultos.
different behavior to that of adults,
La mayoría de veces tiene un
but most of
componente de muchos
cases it
factores.
has a
O sea, no es un solo
multi-factor
factor
component. It's
el
not
que
just
va
a
a
single
explicar el
factor
origen
that's going to
de cualquier
explain the
patología.
origin of
También se
why
puede dar una
a small
explicación
child can
biológica
get
y
a
no solamente
come with
hablamos
oncologic disease. And I'm
de
not only
algunos
talking about
estudios
leukemia.
epidemiológicos que hablan
There are some
de que hay
epidemiological
ciertos
studies that
sectores
indicate that those
que no han tenido
patients
exposición
who have had
temprana
early
a
exposure
ciertas infecciones
to
tienen mayor
certain
riesgo
infections have a
de
higher risk of
desarrollar algún tipo de cáncer a
developing
edades tempranas frente a aquellos, por ejemplo,
early
que
ages
sí han ido a
compared to those
guarderías o sí han
who have
sido
been going to nurseries or have been
medianamente o han
exposed,
entrenado su sistema
early
de
exposed or
defensa
have trained
frente a
their
alguna infección.
in-
Pero también hay
fight against an infections.
otras teorías o asociaciones
But
con
there are
ciertos
other
virus
indications that some viruses
problemas
can trigger
oncológicos en los
oncologic
niños.
issues in
Con
children.
respecto al estado nutricional,
With regards to
que solo el
nutritional
estado
status,
nutricional sea
nutritional status by
causa
itself be
directa de una enfermedad oncológica
cause
como leucemia,
oncology disease
la
of
respuesta es
leukemia,
no,
answer
pero
is
sí,
no,
sí contribuye
but it
a
does contribute
cómo el paciente va a tolerar
the
este
patient is going
tratamiento,
to
¿no? Si
tolerate
nosotros tenemos un paciente que debuta con cáncer
a patient
y tiene de base
who has
algo
cancer and
relacionado
is
con
malnourished,
anemia o alguna otra
anemia, or
deficiencia
some
en
other
nutricional, obviamente
nutritional
su tolerancia
deficiency,
o el
of
aguante
course,
al tratamiento no va a ser el
tolerance
mismo
or
al de un paciente que
response
está
to
con una
treatment is
enfermedad
going to be the
nutricional.
same
No
of that
olvidemos que el cáncer es una
nutritional
enfermedad
status. Let's not forget
hipermetabólica,
that
es
cancer
decir,
is a
que
hypermetabolic
hace
disease.
que el cuerpo
means that the body consumes a lot of energy
lo lleve a desnutrición
and it leads
probablemente, ¿no?
into malnutrition.
Muchas gracias, doctor. La última
Thank you very
pregunta
much. The final
es, ¿qué
question,
medidas preventivas
what
o
preventive
curativas
measures
son las
do
más
you
importantes
consider
para
the most
prevenir
important
niños, niñas y
for
adolescentes?
pediatric
Disculpe,
leukemia?
no escuché preventivas.
Do
Sí,
you mean
medidas
preventive
preventivas.
measures?
Ya.
Yes.
Bueno,
Well,
desafortunadamente,
unfortunately,
no solamente en cáncer pediátrico,
not only for
en
pediatric
algunos
cancer,
cánceres de adultos,
but some
las
cancers
medidas
in adults,
preventivas
the preventive
son
measures
preventivos,
are very few.
entiéndase
You understand
alguna
preventive
conducta que yo
of
voy a
some
tomar para evitar
behavior that I'm
esta
going to
enfermedad, ¿no?
have to
Por
prevent
ejemplo,
the occurrence
¿qué
of the
conducta
disease.
puede ser
For
considerada
example,
como
what
preventiva
behavior could be considered
para
preventive
algún cáncer
for
pediátrico? Es la
some
vacuna
pediatric
contra el
cancer is the
papillomavirus, ¿no? Que
vaccination
inicialmente se
against
vacunan los niños
papillomavirus,
pequeños
HPV.
a partir más o
Today,
menos de
we're
6
vaccinating
años
boys and girls
para reducir, ¿no?
to
O prevenir,
or
reducir el
prevent
riesgo de que
reduce
tengan
the risk
las
of
mujeres
having
cáncer de cuello uterino, pues
cervical cancer
adolescentes,
in women
los varones cáncer de pene o en
or
otras localizaciones
renal
del cuerpo, ¿no?
cancer
Entonces
or
yo
other areas of the
vacuno
world.
a un grupo
So I
poblacional
vaccinate a
para
population group
reducir
to
o
reduce
evitar que se desarrolle
or
la enfermedad.
prevent the development of the
Entonces,
disease.
eso no existe para otros problemas oncológicos. Lo que
We
sí
don't have that
existe es
for other
diagnóstico
oncology problems, but what we
temprano
do have is
y
early
oportuno.
diagnosis or
Entonces,
timely
si yo
diagnosis.
detecto
If I
tempranamente,
do have an
no
early
solo evito la
diagnosis,
enfermedad, pero
I'm not going to
genera
prevent the
mayor
disease, but I'm
posibilidad
going to have
de
a higher
curación y
chance
prevención.
of
Entonces,
cure.
el mensaje es ese, ¿no?
So that's the message,
El pico de
that
leucemia
the
pediátrica,
leukemia, the
el momento
pediatric leukemia
de
peak,
mayor cantidad de casos, ha
where
sido
there's
alrededor
a
de los
large
4 o
number of
5 años.
cases
Ese es un
around
niño
4 or 5 years of age.
pequeño.
So these are
Eso no quiere
relatively
decir
small
que
children.
un niño de 1
That
año,
doesn't mean
de
that a
10
child
o 15
age
años tenga
1
leucemia.
or
Eso no ocurre.
15 can have
La
leukemia.
mayoría de casos,
But
la
most
mayoría
of
de
the cases
adolescentes debuta alrededor de los 5 o 4 años.
start their disease at 4 or 5
Entonces,
years of age.
es una
So
enfermedad
leukemia is
que
also
tiene un tiempo
disease that has
bastante
a
corto.
time of
Por eso es
onset
que
that is
el
quite
apellido de
short.
la leucemia
That's
de estos
why
niños es leucemia aguda. Eso quiere
it's
decir
acute
que si
leukemia
el niño
in children. So
previamente ha estado bien,
the child was previously
y
okay,
4 semanas, 3 semanas,
and
2 semanas antes empieza a
2 or
tener
3 or 4 weeks starts having
fiebre,
pallor,
se siente mal,
fever,
le aparecen
malaise,
ganglios o bolitas en el cuello.
some
Entonces el papá
lymph
lleva al
nodes in
niño
the
y
neck. So the
nosotros
mother
pensamos que
take
es una
or the father takes
infección,
to the doctor.
tiene
We
fiebre,
believe it's an
le da
infection.
algunos
There's a
antibióticos,
fever. We
luego
give them some
ya
antibiotics, but they
1 o 2
don't
semanas
improve.
ya está más
1 or
grave,
2
lo
weeks
llevan a
later,
emergencia porque está
it ends
pálido,
up on the
con
emergency
fiebre,
because the
amanece
anemia
con moretones o
or some
sangrado por la boca,
hematomas or bleeding,
por las plaquetas bajas
bruising
y
because of
puede
low
ser por la
platelet,
misma leucemia o por alguna
and the
infección,
fever
pero está
following an infection of
descompensada,
the leukemia
la
has lost
barriguita
weight,
grande o voluminosa porque el hígado y el vaso han crecido.
and the liver and
Entonces,
the
el
spleen are
mensaje es
large.
tratar
So the
de
message
tener
is to try
consultas
to
regulares con su
understand
pediatra.
and to
¿No?
do
Si un
regular
paciente le
consultations
está
to your
yendo bien, lo
pediatrician.
importante
If
es
the
el
patient is
seguimiento.
going
Y
well,
ese mensaje
we
también es
need to
para
follow them, and that
profesionales de
message
salud.
is
Porque a
also
veces
for all
nosotros
health
como
professionals.
como oncólogos pediatras,
We, as
en
pediatric
la primera
oncologists,
consulta
in the
no
first
llegamos a dar
visit,
un diagnóstico
we don't
definitivo.
make a final
Si es que hay
diagnosis,
sospecha,
but if there's
volvemos a
a
ver al
suspicious,
paciente.
we need to
Entonces, si yo
see
tengo
the
un
patient
paciente
again.
pequeño con
So you have a
fiebre,
small patient with
con
fever, with
ganglios,
lymph nodes, and
podemos
this
tomarle un hematoma
pallor,
para
at
garantizar
least
que la
complete blood
función del
count
riñón
to make
esté bien.
sure that the bone marrow is
Visitarlos
doing
cada
well,
2 semanas para ver
and
cómo
see
van
them
y
a week
consultarlos
later or 2 weeks
regularmente.
later and be in
A
contact with the
veces
family.
más importante
Sometimes
es
it's more
mantener la
important to
sospecha y entender que los
maintain
niños
this high
también
level of
pasan
suspicion and
por,
understand
por
that
cáncer.
children can also have
Excelentes respuestas, doctor.
excellent
Agradecemos las
answer.
preguntas
We thank for all
recibidas.
the
No hemos
questions.
alcanzado a responder todas,
Haven't been
pero
able to
seguiremos
answer all of
gestionando
them, but we will
las
consider them
semanas
to
y
define the
temas
topics of the
pendientes.
following seminars.
En el siguiente espacio y
In the next
para el
space,
cierre, invito
and
a
to
los
close, I
panelistas a
invite
activar
the
sus cámaras
speakers to
y
activate
darnos
their
un breve
videos and
titular
give us
de
a
1 minuto.
final message in
Podemos
1 minute.
comenzar con el
We
doctor
will start
Zapata y
with
luego
Dr.
la
Zapata
doctora
and
Gutiérrez.
then Dr.
Bueno, básicamente, muchas gracias. Ha
Well,
sido
thank you
un
very
honor
much. It's been
iniciar
an
la
honor to share
ponencia con la doctora Sima
this,
y con el
this
colega que presentó anteriormente.
event with
Gracias
Dr.
por
Sima
abrir
and
la
the other colleague.
apertura
Thanks for
a
having
estos
this
temas que son muy
openness for
importantes
topics that are
para
very
la
important
sociedad, no solamente
for
los
the
profesionales
society, not only the
sociosanitarios
health
y todo el
professional, but
staff en
also
general,
the
y
population at large,
felicitarlos
and to congratulate
por la
you
iniciativa
for
y
this
sugerirles
initiative.
que
And
acudan a
I
sus consultas,
suggest to
lleven
visit
a
your
su
doctor, take
pediatra
your children to the
con
pediatrician
cualquier molestia
with, with
nada,
any
muchas
problem.
gracias.
And
Buen día.
thank you very much. Good morning.
Muchas gracias. Adelante,
Go ahead, Dr. Sima.
First of all, thank you very much for the invitation. And I think my main message would be that I consider that securing quality care for children with leukemia is a moral, ethical obligation because it's a totally curable disease. And we know that we are not capturing all the cases globally because some patients don't even make it to the diagnosis. So we need to work on that. We also know that there are more children living in the low middle income country than in the high middle income country, which means to save children with cancer, we have to collaborate with low and middle income country and make sure we help them in this era of very fast moving technology to catch up with what is available in the countries with higher income. So it's a call for collaboration between everyone, institutions, governments, the WHO and foundation. And thank you.
Muchas gracias, doctora. Reiteramos el
Thank you,
agradecimiento.
Doctor. We thank for the excellent presentations of today. We have received many congratulations in our social network. Thank you very much, Dr. Sima Yig and Dr. Manuel Ramirez Orellana and Dr. Arturo Zapata. To all the participants and to the Horas Con El team. Now, Dr. María Carmen Calle has the floor for the closure of this event. Well, my first words are to thank Dr. Arellano, who's not with us here, but Dr. Zapata and Dr. Yiga. This is a extremely important topic, and we have started this block of webinars because we believe that the information should be democratic. We don't need to be updated of what's going on. And I thank Forley and Ruby, who selected leukemia as the first topic, and that this is a topic where there is cure. But however, we're not reaching the percentage that we should have. This is a result of the inequity and inequalities, yes, of course, but it's also a result. Sometimes we miss the diagnosis. Pediatricians, those who look after children, family practitioners, we need to be clear that cancer is also a possibility, no matter how minimal it can be, because when we discuss cancer, that's because the Indian Health Organization has separated pediatric cancer from cancer because the experts in pediatric cancer said it's so little that they don't see us. We need to make it visible, and this is a promise of our institution. We have to put it in the public agenda, in the political agenda, because it's not fair that in some countries they survive and some others they don't. That is unfair. From the ethics and the moral point of view, yes, of course, it goes against ethics and morality. But we need to be updated. We need to be updated, and physicians and health practitioners need to know where we're standing, because if we know where we're standing in this area of the rights of children and adolescents, we know how can we support for an early diagnosis, but not only early diagnosis, but also, I don't know how to say it, Arturo, complete comprehensive diagnosis to know exactly what I'm facing. You adequately mentioned this is not just an ALL. There are subtypes, and we need to get there. And the second part is to provide treatment that is the adequate one. We, the Andean Health Organization, are working for what? We're working for every one of our 6 countries, and maybe others have the highest level of health available, and that means the treatments that with scientific evidence are the most effective. And as Sima mentioned, collaboration is extremely important, as well as solidarity. We acknowledge the work of St. Jude. Since I was the general director, I had the option to discuss with them, and we consider that this in global initiative and everything else is going to receive our support because we definitely do believe that together we're stronger and together we reach further. We invite you to our next webinar. There's going to be, we're going to have a break. When are we going to have our next webinar? Breastfeeding. We have breastfeeding, the upcoming, and we are inviting experts from Johns Hopkins, Washington, and also Latin American experts that are going to talk us about the most recent and why should we continue promoting breastfeeding. There's more and more indication that we need to continue its promotion. Well, thank you very much once again to the speakers, Forley, Ruby, and the entire team of the Anna Health Organization. That week after week, it's possible to share information in health. Thank you very much. Good morning, good afternoon, good evening.